Hello, everyone. I am Amanda Garcia, a conference director for North America with the Public Sector Network. Today, we're joined by Brant Community Healthcare Systems Procurement and Nutrition Services Director, Joe Belancic. Joe brings a rare dual lens to hospital procurement, overseeing not just sourcing strategy, but also operational delivery and nutrition services within a publicly funded Ontario healthcare system. That means he doesn't just see RFPs on paper, he sees how procurement decisions translate into patient care, frontline workflows, vendor accountability, and long term performance. Joe, thank you for joining us for this conversation on what hospital procurement teams in Ontario truly expect from RFP to readiness.
Thank you, Amanda, for the opportunity to provide my insight into the hospital procurement and RFP to readiness practices.
It's our pleasure to have you. So let's go to our first question. Joe, many vendors assume procurement decisions are centralized or standardized across the province, but hospital purchasing is actually far more nuanced. To ground this conversation, can you walk us through how procurement responsibility is typically divided between hospitals, shared services, and provincial frameworks? And what do vendors most often misunderstand about who truly owns decisions, risks, and accountability?
Thank you, Amanda. When I consider all of the different tools at our disposal, those specifically related to procurement responsibilities, uh, we have many different tools at our disposal when it comes to these initiatives. And as you mentioned, these tools include broader public sector guidelines, hospital procurement policies, and legislation and free trade treaties. As we start looking at the framework that we work within, then we go to start applying the different procurement applications. These include things such as direct hospital procurement involvement, shared service organizations, group purchasing organization, and even moving forward to related to provincial and vendor record agreements. When we translate that further into ownership of decisions, and this is quite often, a sticking point that many vendors may not recognize, but it's understanding that risk and delivery really falls upon the hospitals or the
Mhm.
purchasing entities while using these third-party resources, and they facilitate, I guess, the vendors facilitate the use of existing competitive procurement tools, but risk
Mhm.
characterized by length of time, cost, quality, all remain within the purchasing organization.
What stands out in what you've shared is this distinction between tools versus ownership. And hospitals may leverage shared services, GPOs, and provincial vendor of record frameworks, but ultimately, the accountability for cost, quality, and risk still rests with the hospital itself. That's an important reality for vendors. Third party mechanisms don't dilute hospital responsibility, they support it. Let's build on that and go deeper into how care delivery reality shape what ends up inside the RFP itself. So, how do clinical workflows, patient safety considerations, and operational constraints influence how hospitals cope, write, and evaluate RFPs, particularly compared to how vendors often expect those processes to work?
Thank you, Amanda. So quite often, I guess many vendors assume that the commercial attributes are primary, like what's the cost, and move forward from there. However, non-commercial attributes are actually typically top of the RFP process. When we consider overall weighting, non-commercial generally is responsible for between 70 to 80% of the overall weighting of RFPs. And it's also, as we consider, the RFP processes and how we expect those processes to work, it's also important to understand that as we're drafting RFP languages and as we're investigating new technologies, quite often those future state workflows are often difficult to envision because
Mhm.
as our hospital organization or healthcare practitioners, we may not have experienced them firsthand. This reality increases our reliance on previous vendor implementations at peer hospitals and other service providers. Similarly, RFP language is often shaped by previous RFPs used both internally and by other parties. Improvements related to technology, namely, for example, AI, have opened the door to leverage RFP scopes and languages and also help improve outcomes in the future.
What you've described, Joe, is critical. Cost may only represent 20 to 30% of scoring. And while non commercial factors like workflows and patient safety, rather, carry significant weight, you also highlighted something many vendors overlook. Future state workflows are hard to envision if clinicians haven't experienced them. So that increases reliance on peer implementations and real world proof. So let's talk about engagement because shaping language early can influence outcomes significantly. And there's often a fine line between helpful vendor engagement and problematic influence. From your experience, Joe, what types of vendor engagement before and during an RFP actually help hospitals make better decisions? And what behaviors tend to create friction or raise red flags once a procurement is underway?
So, from I guess my own personal perspective is that I've always been a proponent of early vendor engagement involvement, and this is as long as it's done within the appropriate means through the necessary procurement groups, as opposed to influencing the RFP outcomes. So when we sort of consider early vendor involvement, it helps shape the language and prioritize service features and functionalities of both equipment and non-equipment providers. It also helps with gauging the current temperature of the market. For
Mhm,
example, without speaking to our vendor base, and I find them as, as a very important aspect
mhm,
of information and of what the market's doing. Is it the appropriate time? Is there other
mhm,
factors that are influencing what the market pricing and volatility is going to be at this particular time, or even equipment availability or service availability?
mhm,
So it's important to address that even prior to RFP issue. And then similarly, going back to early vendor involvement,
mhm,
it's imperative that we include purchasing representation as part of our vendor involvement. Quite often that we have vendors that try to, I guess, undermine or I guess usurp purchasing activities and try to engage clinicians directly in the hope of securing
mhm,
non-competitive contracts and gaining inside track and sourcing. However, what's happened is that this has led to the creation of vendor relations policies to limit direct
mhm,
contact, set boundaries, communications, trials, and sales pitches.
mhm, mhm,
I've one further point I'd like to add is that I've also personally experienced a situation where incumbents have actually experienced many situations where incumbent suppliers have attempted to influence a sourcing outcome through direct contact. Those direct contacts inevitably result in higher initial pricing,
mhm,
and actually creates an environment where we're actively looking at alternate vendors because of that purpose,
mhm, mhm.
because of the non-competitive nature of the pricing that's, and ultimately the pricing becomes more competitive as we increase the competition in the market.
I appreciate how candid you were about that experience with incumbent influence and how competitive tension ultimately corrected pricing. And you've made something very clear. Early engagement can be valuable, but only when it includes procurement representation and respects process discipline. And that reinforces a broader theme here in healthcare. Trust and governance matter just as much as innovation. So let's move from engagement to evaluation. So many vendors believe that meeting technical specification is enough. But in a hospital setting, compliance is often just a baseline. When reviewing proposals, what differentiates vendors who truly understand hospital environments, particularly around implementation risk, change management, and adoption, versus those who simply check technical boxes?
When I think of the vendor proposals that I've received in the past related
Mhm,
to those technical requirements versus an all-encompassing proposal, I
mhm,
always think of the implementation plan, right?
yeah.
Those vendors that have gone through extensive experiences and research
Mhm,
have considered the resources available from hospital teams, as we all realize they can be limited based on our
mhm,
current environment, and
yeah.
also creating realistic timelines around the implementation plans. Um, Strategic and organizational plans should also be considered as we start gathering data. Uh, and on the current platform, this is part of those pre-implementation readiness. We also consider engagement of stakeholders and determining change management communication plans, all of which are critical as we start looking at new project implementation. And that all-encompassing implementation plan and project planning is imperative when we start considering how effective any new technologies will be to put in place. When we think of new and shiny pieces of equipment or software, they become ineffective very quickly. Without that comprehensive change management plan. And for example, I've also met with, with a vendor to consider patient service requests and automating some of those practices. One of the key questions I raised was related to adoption rates amongst the patient population. If we're looking at implementing technology and simplifying those activities, what do we hope to gain from it? When I guess upon further conversation discussion, we found out that some of those adoption rates were only 5%, given technical challenges and even considering the patient populations. As a result, when we start doing a deeper dive in some of these activities, the ROIs some cases do not support the investment.
Yeah, that example of the 5% adoption rate is powerful. It reinforces something procurement leaders understand deeply. A technically impressive solution becomes ineffective without operational readiness and realistic change management. So you've emphasized realism, stakeholder engagement, and implementation planning. And it's not just about capability, which naturally brings us to long-term memory and performance. So even though each RFP must stand independently and remain fair, hospitals are human systems. They remember experiences. So once a solution is awarded, how does the vendor's performance during implementation and early operations influence hospital confidence in future procurements, renewals, or expansions, even when each RFP must remain fair and independent?
So I guess it's actually a very interesting question, and it makes me consider how the award process works and how in fact the follow-up processes that happen thereafter.
Mhm.
So once a solution is awarded, um, RFP bids must be considered standalone during the RFP process, right? So this is where we look at the only activity that we can come back to is on past performance is in relation to references, which can impact scoring if the vendor chooses to include a kind of a current solution. However, when we consider going one step further is vendor performance evaluations and business reviews, as they're important to identify performance challenges and deficiencies with any solutions. When we organizationally, when we consider vendor performance, we also tie that to contractual language, relation to the termination, whether or not service levels are met, service level agreements, and remedies related to service levels. However, the challenges we mentioned resources, quite often vendor management may not be the top priority for many organizations as we focus on the next fire of the day. Documenting and communicating these deficiencies are extremely important as the primary methods to influence vendor performance and contractual compliance. Our particular RFPs include languages where bar vendors from participating in bids should they be terminated contracts or a legal dispute. So ultimately, it's really up to the organization to manage the vendors, and based on that vendor management, determine whether or not they're applicable for future RFP bid opportunities.
So I'm hearing formal documentation, SLAs, and vendor management may not always be glamorous, but they become critical signals over time. And hospitals remember delivery performance, not just promises. And your point about bearing vendors with terminated contracts or legal disputes sends a very strong message. Performance history matters. So let's close with this. What is one expectation you wish healthcare technology vendors better understood when responding to hospital RFPs in Ontario? Something that would immediately improve proposal quality and reduce burden on procurement, IT, and clinical reviewers.
When I think of RFPs, and especially around technology, is that it's important to note that healthcare practitioners are good at providing patient care. And that's the core function of most healthcare institutions. However, they may not be the subject matter experts in relation to new technologies or familiar with the complete scope of services that we're going out for. Many clinicians work in a specific area of practice for a long period of time and may not have been exposed to the full solution or even our current solution in terms of all the end-to-end practices, because we're mired in the day-to-day. So what I would encourage is that vendors should expect to factor in a certain level of ambiguity in the RFPs, because, well, we don't know what we don't know. As many existing solutions have been maybe out of dated or predated most staff members that are actually working within them. The other aspect to consider is that high levels of technical jargon within the RFP document may be lost in the reviewers. While our IT teams are primarily interested in integration, system requirements, and ongoing support, many may not understand what in fact those specific activities may be, or those systems may incorporate. However, like something as simple as a feature benefit statement go a long way. And also similarly, system capabilities, specifically like those technical features, are often addressed during on-site visits, demos, and presentations. The depth and the breadth of highly technical proposals are quite often pushing clinicians away from evaluating the bid, as they lack the time and expertise to evaluate those proposals in their entirety.
Joe, what you underscored is something very important in every healthcare technology vendor should write down. Hospitals are not always subject matter experts in emerging technologies, and overwhelming them with technical jargon does not build credibility. But clarity, visibility, simplicity, feature and benefit clarity, realistic integration planning, and respect for limited clinical review time. That's what strengthens proposals. Joe, thank you for this honest and grounded perspective on hospital procurement in Ontario. This has been incredibly valuable for vendors who want to move from simply responding to RFPs to truly being procurement ready. Any last words?
Thank you for the opportunity, and to both Amanda and the Public Sector Network. And I'm happy to provide any insight I can to smooth out these processes.
Thank you so much, Joe.
Thank you.